much, Kelly, and I'll just load up I'll just load up my slides. You see that okay? Yeah, great. So thanks again, Kelly, for that very warm and kind introduction. So yes, I'm Shaun Qureshi. I am here in Canada, but I'm from Scotland in the United Kingdom. And today I have the privilege to be speaking to you about some of research that I have been carrying out and with collaborators recently in my role as a research fellow at the Centre for the Art of Dying Well, which is based at St Mary's University in London. The presentation that I'm going to be giving is this: autonomy, the internet, and end of life. How people face death and bereavement. How people facing death and bereavement resist the medicalisation of dying and grief through online forums. And you probably spotted the dog on my first slide. And hopefully by the end of the presentation, you understand a bit more why I've chosen a photo which shows both a computer and a dog for the first slide. Before launching in, I was going to say just a couple of words about myself, but I mean, Kelly's already given such a great summary, but like you've heard, I am a palliative care physician in Scotland, currently focused on research, education and public health advocacy work in palliative care, connected to the Centre for the Art of Dying Well, as I've mentioned, and currently in North America as a Churchill Fellow, being supported by the UK Churchill Fellowship to carry out a kind of exploratory traveling project so that I can learn from models of care here, which are successful in providing palliative care for people who are marginalized, because I'm very interested in taking this learning back to the UK with me and doing work in the future to try to reach people who currently are underserved by our current systems of palliative care. So I'm very thankful for Kelly to be hosting me at the moment, and for the opportunity I have to learn from her and from her colleagues here in Victoria. So it's a really great experience. However, that's not the project I'm going to be talking about with the rest of the presentation, but you will see that the themes of equality and in palliative care do come through as well. So in terms of what I'm going to be presenting to you today, it's really an interdisciplinary project where we've collaborated with colleagues from different disciplines, and we've also drawn on knowledge and approaches from different disciplines as well. So we've combined kind of artificial intelligence, machine learning, and natural language processing with more traditional human-led qualitative data analysis, and drawn on kind of traditions from sociological research, palliative care research, and policy, and using that to explore issues related to medicalisation, digital technology and its role in death and grief, and also dying and grief during the age of COVID-19. So for me, I mean, this has been a great experience doing this work, and it's been hugely interesting, and I hope that you find it interesting as well. And I'd definitely be interested at the end to hear what your thoughts are and how you think that what parallels you think there might be to the context that you're in as well, when we have time for discussion at the end. So I will be going into the background that kind of underpins the research that we undertook, and the theoretical framework that we use to ground this work, talk about what our objective, what we aim to do, then how we did it through our methodology, going into some of the salient findings, and then the discussion of what the findings might mean and what the implications are for policy and practice, and then hoping that there'll be time for general discussion at the end. So to start with then, the background, and really getting into what I mean when I say medicalisation. So, sorry, I'll go back a slide. So by medicalisation, I'm referring to really a term that's used in the literature for the pervasive social consequences of medicine on all aspects of social life, which has been advancing since quote unquote improvements in healthcare
but certainly the expansion of healthcare, it's from the 19th century onwards, but it's resulting in a system where you have the physicians. There's kind of highly trained, university trained, privileged individuals, but their effects, the effects of their existence and their decision making affects everyone else in society, including the most disadvantaged in society, affecting all aspects of human existence. So the idea of medicalisation is not just that there's a power imbalance when you are during your hospital appointment or during your doctor's appointment while you're in the doctor's office, but actually through the lens of healthcare, through the lens of medicine, actually what would historically have been seen, things which would historically have been seen as components of human existence, just parts of your life, either positive or negative, are seen as separate from your existence, as problems to be solved and endured until they can be solved. And critics of medicalisation feel that it can prevent people from being able to cope on their own, and also to assert authority over their own bodies, are reducing any capacity or freedom to try to sort out problems in your life for yourself. So a simple example of this might be restricting or criminalizing people who try to use medication to cope with their own problems. But if you think that a doctor has the power to really say to one person, your problems are legitimate, but say to another person, your problems are not legitimate, and can even say to someone else who's completely uncomplaining and doesn't believe that they have any problems, that tell them that they have a problem. So but what we're going to be talking about more specifically in this presentation is medicalisation in terms of dying and grief. So historically, scholars speak about pre-modern death, historical death, as being tamed. So that's not to say that it was seen as being a good thing, but more that it was seen as being a natural part of life. Death happened in the community, surrounded by one's loved ones, and the aspiration was that you died at peace with God. But then around the time of medicalisation and advances in medicine and organized healthcare, this needed to be rationalized. So death not as a spiritual experience, but as what must be a scientific one. And since illness is so bad, illness is so bad and must be solved, death must then be a failure to defeat illness. So death was seen as a failure. The dying person was removed from the community and taken into the domain of the hospital under the control of the doctor. And death was no longer seen as tame, but instead something dirty, polluting, scandalous. And I think many of us who are on this call are probably familiar with the idea of kind of iatrogenic disease, iatrogenesis, where healthcare, surgery, interventions, medicines actually cause health problems rather than help. But Ivan Illich, the theologian and philosopher, argued that actually medicalisation caused structural iatrogenesis, so iatrogenic problems at a society-wide level, where aging and dying were seen as medical illnesses, leaving entire societies less able to deal with these processes, even though they're natural. So dying, certainly 19th century going into the 20th century, was not an individualized process, but one where the professional voices were amplified and the dying person was excluded from decisions affecting them. And there was an expectation of control over emotions and bodily processes. And that expectation of control of emotions extended to bereaved people and people who were losing a loved one as well. However, when it came around the time of the middle of the 20th century, there was significant discontent with what people observed, what people knew what was happening. There's discontent with the medicalisation of death, dying, and grief, and really the fact that people could see that dying people were not having a good quality of death. So the death revivalist movement emerged, working to change discourses around death with the aim that the dying person in late modernity should participate in the organization of their own dying process, be told the truth about their condition, not have it hidden from them, and have agency to make their own end-of-life decisions.
also aiming to increase societal awareness of dying and death and to break down social taboos around discussing it. And from this came the ideas of the good death. So an ideal of a dying person who accepts that they're dying, has their identity preserved, their wishes are met, and their family are present at the time of the death. And in opposition, the bad death, one which is invasive, over-medicalised, disempowering for the dying person, and there's no acceptance of death before it occurs. And from these ideas, the modern hospice movement emerged, where modern hospices were meant to be places that provide care to meet the needs of dying people, given to people on the basis of need rather than any other factor, and it provides care in a different context, completely different perspective from what was available in other healthcare settings at the time. And following that was the emergence of what we call palliative care, which is often stated aim is to prevent and relieve the health-related suffering of adults and children facing life-threatening illness, including providing care which is physical, psychological, social, and spiritual, and it's meant to improve the quality of life for caregivers of dying people as well. And this was a very revolutionary idea in the mid and late second half of the 20th century, and intentionally ran very contrary to what was available from mainstream biomedical approaches to care for the dying person. So those of us who are quite keenly involved with palliative care may at this point be feeling a slight tinge of cynicism at this point, because you may be thinking, well, that all sounds lovely, but I do wonder whether these aspirations of palliative care have been met, are being met. And that brings us on nicely to the concept of the remedicalisation of dying and grief, which is really the idea that the aspirations of death revivalism, including palliative care, have floundered over time, but just by its proponents becoming increasingly institutionalized and failing to meet their stated premise. So, and I know that this and what I'm saying and what this entire presentation is very Westocentric, and I apologize for that, but thinking about the global north, high-income countries, the St. Christopher's Hospice in London opened in 1967 with the advent of the modern hospice movement. We're now in 2023, and deaths still, by a large margin, mainly occur in institutions, still hidden away in hospitals, hospices, or care homes. And medical decision-making is still central in the dying process. Even when people die at home, this is still very professionally organized, supervised. And also, when it comes to people who are having their needs met at the end of life, there's many people who are excluded from that and from accessing palliative care, including the poorest people in our societies, people from racialized minorities, people who have low levels of health literacy or are otherwise not equipped to advocate for themselves, maybe the same way that someone else would. And certainly, I think back to like the specialist palliative care community in Scotland, to me, in my opinion, is a system which is very staffed by white upper middle class people, providing care in a system which works best for white middle class people. But there's many other people in our communities who have significant palliative care needs who are not benefiting from that system. There's also, further criticisms of how the death revival, the consequences of the death revival movement have been integrated into our society. Criticism of the idea of the expectation now of the dying person having self-mastery. So the doctor might say to the person, "Oh, I'm not in control of you. You're in control of yourself now." But why does the dying person need to be in control? Why, if we accept that dying is a natural part of life and nothing to be ashamed of, then why should there be an expectation that the dying person would would be anything other than emotional, distressed, maybe smelly, maybe excreting waste products, maybe doing presenting to us in other ways which are not which don't fit with the typical uptight sensibilities, but are maybe a natural part of dying for that person and a completely understandable part of dying for that person. And yet there's still an expectation for the dying person to be virtuous, to exert emotional labor and face their situation as a hero and be uncomplaining about it. Furthermore, the hospice movement has sought legitimacy by becoming increasingly aligned with mainstream healthcare. And in my opinion, the result of that has not been mainstream healthcare becoming more like palliative care. The result has been palliative care becoming more like the mainstream healthcare system, which it originally intended to be a stark contrast from. But with the increased influence of the medicalised model, the palliative care hospice movement could be criticised for losing its original charismatic character and values, becoming increasingly restricted and inflexible and due to bureaucratization. And I know that, and that this is kind of corroborated by the literature as well, that actually for healthcare professionals providing end-of-life care, there's kind of a moral injury or dilemma because they're aware of of what a good death should be, this ideal of the good death, but aware that in the systems in which we operate, it's not possible to provide that really, certainly not for most people. So now healthcare professionals, including palliative care professionals, have to operate to a different standard, which is the good enough death. That we're not going to get this person to the good death, but what can we do in the circumstances that we're in to make it good enough, or at least make it better than it is? And we also are in a situation in our recent history where grief can still be pathologized. You can be diagnosed with a psychiatric disorder if you are experiencing or showing signs of grief which are deemed to go on for too long or be more intense compared to what would normally be socially accepted in your society. I cannot talk about medicalisation of death and dying without mentioning the COVID-19 pandemic, which, as you will see, is also relevant to the findings of this research. So the COVID-19 pandemic has unfortunately provided additional challenges for dying people, their caregivers, and those who are grieving. So far, approximately 7 million people have died worldwide from COVID-19. And the idea of the risk of death has had an effect on both the public and healthcare professionals and in their kind of consciousness of death and dying. As well as that, I mean, public health rules have had practical effects on reducing people's ability to partake in, reduce people's ability to have the care at the end of life that would have been ideal for them, and people's ability to partake in normal social rituals around bereavement and grief. So those public health rules include limitations on visiting others, restrictions on visiting hospitals and care homes, people dying alone in institutionalized settings, preferences regarding the end of life not being met, restrictions on funerals and public grieving, and lack of opportunity for in-person support. And all the while, all the social inequalities have just got worse throughout the pandemic as well. I did want to briefly mention as part of the background, as this is also digital research, the concepts of the digital and the post-digital. And scholars of industry do describe us as now as being in the fourth industrial revolution, which is characterized by aspects including automation and data exchange and manufacturing, cloud technologies, and AI. But from a social science point of view, we could be said to be in the post-digital age, where technology informs a really tacit aspect of human life, not as an adjunct, but absolutely entangled and incorporated into human existence. So I find it helpful to think about the post-digital age as being kind of parallel to the pre-digital age, you think about the ancient past when digital technologies didn't exist, and nobody thought, oh, I'm going to use the digital technology now. But then we had the digital age where people very consciously were thinking, oh, I'm going to use technology now. I'm going to go online now, and then I'm going to stop. I'm going to go offline. Whereas we have moved past that now, where there's just really an assumption that actually we always have access to digital technology, and people don't consciously think about a separation from their life and digital usage in the same way. This is also relevant to healthcare and palliative care. Health services being under pressure to innovate and meet the needs of an increasingly frail population with very limited resources. And digitalization has the potential to improve healthcare, and it may have a role in empowering patients and including helping them to maintain autonomy, especially those who are currently underserved. The pandemic has also led to rapid advancement in kind of the distribution of digital health technology, and also had effects on people finding like telehealth and other digital health options acceptable. And when it comes to care of the dying and the digital, certainly in the palliative care world, questions about technology and its role in palliative end-of-life care have been raised, which I think are really very relevant to this research. So questions like, what can digital data tell us about the experiences of dying people? How can internet-based material provide self-help and education? How can technology support patients and caregivers? How can digital palliative care interventions align with patient and caregiver values and goals? And I think that those are questions that we explore with this research, and go further to ask, how can the needs of dying people and their caregivers be met in the context of the post-digital age? And how does the use of technology relate to people negotiating autonomy and medicalisation when facing dying and grief? So what we set out to do, we identified social media as being a fruitful area in which to study. Social media has an important role in communicating messages, but also shapes how people communicate, but also shapes how people have experiences in the first place. So we recognized the potential benefits, including that the social media would allow, and online forums would allow people to freely express their experiences away from the constraints of medical establishment, but also aware that social media can be unjust, exploitative, and can limit people's access to knowledge as well as facilitating. So we set out with this research to investigate how people living with life-limiting illness and their loved ones experience, negotiate, and resist the medicalisation of dying and grief through online internet forums. And although it wasn't our stated aim, this study does incorporate data from the onset of the pandemic as well. So almost a kind of a secondary aim has been to add to knowledge about how medicalisation has impacted dying, death, and grief during the pandemic. So I've said what we set out to do. I mean, I'll move on to tell you briefly how we set about doing this. So we identified online forums focusing on dying and grief, including those used by people who had life-limiting illness themselves, people who were caregivers, and people experiencing bereavement. And we used a machine learning and natural language processing techniques to categorize a large data set. So starting off with this suite of programs called Method 52, which was developed by some colleagues of mine, and that conducted web scraping to go out and gather thousands and thousands of online forum posts and save them to a database. So we carried that out in September 2020 to obtain retrospective data, and we didn't define a start date that we were interested in. We just asked the program to collect as much data as it could going back in the past. And before any further analysis, after the data was collected, it was stripped from anything identifiable, including usernames, metadata, images, and URLs. So I will, when I get to the results, I will go into numbers a little bit, but just at this stage, once we had collected that data from those online forums, at this stage we had well over 100,000 posts to get through. So at this stage, we needed a way to try to start to curate this. So it started off with this natural language processing technique called clustering to aid discovery of characteristic terms, phrases, and discussions within a large data set. So we use this to start to categorize the data, even if those were just provisional categories. So firstly, let the machine run with it by itself in an unsupervised way to see what it came up with. But then there were repeated iterations with human interpretation and machine training as my colleagues kept checking what the machine came back with and then tried to train the machine again to do this more efficiently. And after this ran, we had started to develop initial categories, but there was still huge amount of this. So those categories made it more manageable, but there's still a huge amount of data, and much of it was not relevant to answering the research question. So at this stage, we had to. It's still too much to manually go through and work out what should be included and what shouldn't be included. So the next NLP method was called NLP classification, which identified posts containing those initial categories which were developed by the clusters were then used to generate keywords that might be relevant to those clusters. And then the NLP classification identified posts containing a term which was likely to be relevant to that specific category. But then again, with repeated iterations of the operators, the program was trained over time to judge whether posts that it was analyzing were likely to be relevant or irrelevant. And so irrelevant posts started to be excluded from further analysis. And kind of as a complement to this, this ran alongside, we also ran surprising phrase detection, which was where our foreground data, so all the posts that we had obtained from the internet, was compared against a background of which we used the whole of Wikipedia's English language website. And the foreground data was, the language of the foreground data was checked to see how surprising the language was. And it was judged as surprising if words and phrases were coming up much more frequently than you would expect compared to the background data. And so when these surprising phrases started to come up, it started to make us think, oh, this could be a theme. Or this could be relevant for, or this is worth including for further analysis to see if this is going to develop into a theme as people are talking about this. And so this also did ensure, kind of as a separate, it ran parallel to the NLP classification, but it did ensure that we were including relevant data which may have been missed through other processes. And then so after we had got to that stage, we had excluded a large amount of posts, but we're still left with more than 7,000 posts which underwent inductive thematic analysis. We didn't use a pre-established framework because we wanted we wanted our analysis to be guided really by the language we were finding in the post from first principles. But it did build upon the initial categorization which occurred by the machine, but when I show you the themes that resulted, those are themes that were ultimately determined by us and other human beings. And yeah, as we progressed, we discussed the themes that were emerging within the research group to ensure that to just increase robustness and ensure that there was a team agreement that the findings were grounded in the data. I just want to say something briefly about ethics, because we are aware that the people who were using these forums, who were dying or who were bereaved, are very vulnerable, and we took the ethical aspects very seriously. We made a commitment to only include data which we felt was reasonably expected to be public. So going to very large forums that were easily accessible through search engines with no logins needed, and there were no rules against automatic data collection and or extracting data. And we've stripped all the data of anything identifiable. And actually, even when I present data extracts, they have been bolderized. So we've changed the wording so that hopefully at least the majority of the meaning is still conveyed, but someone would not be able to go away and Google those words and find the original post. We also, in agreement with our research ethics committee, made every effort to exclude any data from any person under the age of 18. And we did get research ethics approval by the Research Ethics Committee of St. Mary's University, London. So this is just kind of an overview summary of the methodological process. So originally collecting the posts through method 52, obtaining 116,748 posts through data scraping, and then initial categorization through clustering analysis. And then through a process of refining inclusion and exclusion for further analysis, we used surprising phrase detection and NLP classification, ending up with 7,048 posts for the final analysis, which was carried out through inductive thematic analysis. So now on to the findings. So as I said, we hadn't predefined a start date of interest, but by the time we just wanted to get data as far back as possible. So that ended up being 2003. So we have data from 2003 to 2020. If you can't see this graph clearly, don't worry. I just wanted to give the impression that over time, the volume of posts was increasing. And hopefully you can see that around 2020 and during 2020, there was a major increase in the volume of posts. As a result of the thematic analysis, we did generate three major themes: the theme of comfort, the theme of community, and the theme of capability. And you may be pleased to hear that since we're talking about a volume of over 7,000 posts, I am not going to go into full detail about these results. But what I want to do is just give you just an overview so you get the salient points. So when I speak about when the theme of comfort relates to forum users seeking support to ease their suffering. So this is people who have life-limiting illness themselves or a caregiver or have been bereaved. And the need for comfort may be exacerbated by experiencing uncertainty, pain, or fear. And there may be barriers to obtaining adequate comfort. So forum users felt they were provided with a sense of solidarity and recognition, which maybe we weren't obtaining in their offline life. They said, our like button is a way to tell others they've been heard. We also frequently noted that forum users expressed grief for long periods of time, often when it was felt that they felt it was no longer socially acceptable to grieve, or that any bereavement support service they had been offered was now finished. And they were able to use online forums at any time of day or night, unlike other services, which may be only office hours or with appointment. Forum users also shared their sources of comfort, which very often related to animals. But other sources of comfort included beliefs, including spiritual, religious, philosophical, and existential beliefs. And users noted that these were things which were important to them, important to their experience, but they weren't able to explore these or talk about these in their interactions with healthcare professionals. There are also barriers to obtaining adequate comfort. So those many users expressed frustration at the constraints and the challenges of the system in which they were in, including frustrations around unpaid carers and caring for loved ones who were in care homes. And these challenges increased after the onset of the COVID-19 pandemic. Although the people were using the forums to express these frustrations about the lack of support they were receiving, they did also express the value that they found in having the online forums. So the next theme is the major theme of community, which relates to how online forums provide a community where forum users could build relationships based on mutual trust and shared experiences. So this was, so some users even spoke about how they found it difficult to engage with kind of online or in-person support groups, but in contrast, online forums provided an environment where they felt free to express their feelings, but could engage as much or as little as they wanted and enter and leave discussions freely. And this could be distributed over a long period of time, or people could go away and return repeatedly. There was also discussion of how COVID had affected community, but how advice about how they could create or sustain community during COVID. So remembering that a lot of our data since the onset of the pandemic has been from 2020, so at which time the use of video conferencing software, widespread use, was still probably new to a lot of the forum users. So there was a lot of discussion about the merits of video conferencing software, for example, being able to see someone's face, which they may not have been able to do if they went in person and their face was obscured by a mask. But not everyone found video conferencing software to be effective. And actually, some users even preferred the use of online forums still compared to video conferencing because they preferred having the asynchronicity of it and find that more conducive to their needs compared to sitting in an hour-long Zoom meeting, which started and finished at a specific time, for example. And the last major theme I'm going to discuss is that of capability, which I found to be I found this to be the most surprising of the findings, which was that forum users actually use the forums to build their own capabilities. And this is done through information seeking and giving. And this can include information on managing technicalities like legal documents, self-managing symptoms, and information for relatives and carers seeking to know what to expect when a person is dying, and information about grieving as well. So many users expressed that they felt that their capabilities were limited by the systems in which they were in. They expressed feelings of disempowerment and really a strong sense that they were engaging with a healthcare system or a care system in which they must battle against. However, the users described that online forums actually allowed them to better navigate these systems and potentially be treated better within it. They may counteract threatened agency through offering practical advice. And we find people sharing information on things from medical procedures to suggested actions on an online campaign or suggestions how to get in contact with the media. And we often, sometimes users would express that they'd been carers for years, but it wasn't until they'd come to that online forum that they actually found out for the first time that they had these legal rights that they didn't know about, or they had access to these benefits that they'd never heard of before. And again, unfortunately, things were worse during COVID, and this did threaten people's capabilities. And many users expressed poor experiences that they'd had with the systems during the pandemic, including a lack of or delayed communication from health services, being kept out of meetings, feeling relegated, or feeling ignored by what the government was concentrating on during the time of crisis. So discuss a little bit about what this means and from a practical standpoint, and also within the framework of medicalisation. So we saw that the volume of posts increased over time, which is consistent with increasing digitalisation and increasing familiarity with the internet that occurred over the study period. And there was a substantial leap in 2020, which corresponds with the onset of the COVID-19 pandemic. Online forums have been shown to be a place where people can express their feelings or concerns about their experience and facilitate support and comfort. And through analysis of what people are experiencing, we can see that in many cases, people are experiencing dying and grief in a way which is contrary to the apparent motivations of the death revivalist movement and palliative care, still under the surveillance of healthcare professionals with needs and wishes often being unmet. So systems like our healthcare system, which are ostensibly meant to help dying people and their loved ones, are being experienced as actual opponents, forces against which people must fight. And we spoke about some of the barriers to having wishes met at the end of life during the pandemic, including social isolation, having no family accompaniment at the point of death, and a lack of in-person opportunities to grieve. But online forums can provide support which may be perceived as better in quality, quantity, and duration compared to what is available from formal structures, and may compensate for inadequacies which are encountered offline. We have also shown that people have different priorities and values, such as animal companions and metaphysical beliefs, which are not accounted for or acknowledged by the medical model of dying and grief. And also that forum users express grief for extended periods of time, which have outlasted any offline support that they've received. And lastly, that online forums can themselves be can be tools to mitigate problems experienced by those facing dying and grief, and providing guidance which is not available or is made difficult to find or made difficult to understand elsewhere. And while care systems are viewed to be obstructive, online forums may compensate for that and provide tools to overcome systemic difficulties. But we also need to be conscious of the potential downsides of online forums. Yes, they're flexible. Yes, they're accessible, but useful information is vulnerable to deletion or change. There's potential for abuse of people who are already vulnerable, and there's potential for disinformation spreading as well. So I'll just skip over this. So what are the implications then? What does this mean in terms of policy and practice? So, well, obviously, current conditions for people experiencing dying and grief do not correspond with the patient-centered aspirations of death revivalism and palliative care. Yeah, just what we need to see now, in my belief, is future development and investment in online forums, which makes explicit that online forums are a valuable part of the toolkit for people who are dying or who are experiencing bereavement. And obviously there needs to be future work done in this direction, which leads to transformative change. It's not to say that this is a solution or a replacement for mainstream services. Obviously, mainstream services need to improve as well, but this certainly is a useful adjunct and potential help to allow people to maintain their autonomy. So I don't know what shape this transformative change needs to be to our overall model, our overall approach to people who are dying or bereaved, which incorporates online forums. And I think whatever transformative work, whatever development work takes place, it needs to center people with life-limiting illness and people who are grieving, incorporate them as co-researchers. But some ideas about what that might look like in the future is making explicit the role of online forums for people experiencing dying and grief, because I don't think that it's necessarily well known to the person affected, and it's certainly not well known to healthcare professionals that these resources exist. Incentivizing and rewarding civic labor, ensuring the legacy of important data and information, counteracting exploitation, and providing training in digital skills. But we also need to be conscious of the risks of routinization, which I've spoken about. So with too much oversight, with too much professional interference, actually the original value of these grassroots forums, which provide individuals with agency, that could be lost. So all of this, whatever shape this takes going forward, it needs to be done sensitively and needs to be thought out very well. So
conclusions. I'll just finally wrap up. You can probably tell by now that I like animals as well. So to summarize what we've spoken about today, so the medicalisation or remedicalisation of dying and grief, whatever way you want to look at it. And we've spoken about how that encompasses a societal approach, including dying people being disempowered in relation to the healthcare professionals, dying people being institutionalised away from the community. But online forums allow dying people, their caregivers, and grieving people to negotiate and resist this remedicalisation by experiencing support and comfort beyond the constraints of mainstream systems. The concerns and values of dying people, including animals and spirituality, are far removed from the medicalised model of dying. And online forums allow people to retain or regain autonomy, become empowered to challenge disempowering power structures by making bureaucratic processes and information on legal rights more transparent and easier to navigate for them. And the value of community-led online forums has significant implications, I believe, for policy and practice as society continually advances into the post-digital age, and we have to think about what that looks like for dying people and their loved ones. So future work must develop new models where online forums can be integrated into existing systems, made transparent and accessible, and be optimally funded, structured, and sustainable. So I will just quickly thank my co-authors, the team at the Centre for the Analysis of Social Media, who carried out the machine learning and NLP techniques, and Maggie and Karen at the Centre for the Art of Dying Well, and Amy at the International Observatory on End-of-Life Care, and of course to our funders, the Plater Trust and the UKRI Enhancement Culture Fund. Thank you very much for listening to my presentation. Be great if we still have some time.